but I just know the epidural is the worst one. Your subdural hematoma could probably take a while to develop. And then your subdermal hematoma, often misinterpret as vascular disease like stroke, TIAs, dementia. All right, last thing for this one. That's pretty much it for your head things. I'm just going to go over. So your diagnostics, CT scan. That's the best one that's going to show you everything. Your major focus as a nurse for these is to treat or prevent ICP. And you're always, when you don't know what type of skull fracture it is, you're always going to kind of just avoid an NG tube placement. I think that's big for her. You're never going to put, if you suspect any type of head trauma, you're never going to put in an NG tube. It can go up into the brain, especially, I think, specifically for the basilar skull fracture. Pull that out for you just in case I'm not saying it right. Your basilar skull fracture, you're always going to not put in an NG tube. But if you don't know what type it is, NG tube should not be placed in at all. And then no sneezing and no blowing the nose. And that's pretty much it for your head injuries. I am going to go over some random things before I get to your next ones.
Hey, Sam, I have a question.
Yeah.
You guys hear echo?
Yep.
Sorry about that.
It's okay.
So is it safe to say then if they have a skull fracture, no NG tube, and since we're managing the ICP, also no lumbar puncture, right?
Yes. I highly suggest, let me see if I can fix this thing. I highly suggest you looking up pictures online of what each lobe in the brain does. I'm trying to show you what my picture looks like, but it's just not popping up. There it is. Okay, let's see. So I just looked up anything. This is what mine looks like. I suggest you look up, oh. There. I suggest you just look up Google functions of the lobes images, and then look up these things that give you lists of what each lobe does. But an important one to kind of focus on, your frontal lobe, is for speaking and swallowing. Your brainstem is for heart rate and breathing. Your cerebellum is for balance, equilibrium. I think that's the only pulmonary ones. Yeah, I didn't really pay attention to. There's 3 more, but I would just pay attention to kind of these ones. Your temporal lobe is kind of like your hearing. I can put that in there. I've looked up a bunch of these pictures online, and I suggest you do the same because they kind of like, they all change differently. This is what my next one looks like. And they kind of just tell you different things. I would just look them up and kind of know. Like a temporal lobe is kind of like auditory, so you're hearing. It could be language comprehension, so your Wernicke's area. And the next thing I suggest you looking up is your cranial nerves. I would know your cranial nerves. There is a box in your book, 56-3 is mine, and it literally just gives you a list of all of the cranial nerves. I'm going to tell you right now that 3, 4, and 6, your eyes are usually the ones that are going to be affected. So the 3, 4, and 6 are usually affected. That is your ocular, motor, your trochlear.
Did you say 3, 4, and 6, or is it 3, 4, 5?
Oh, 3, 4. Hold on. 6. 3, 4, and 6.
Okay, thank you.
Your ocular, motor, your trochlear, And then your abducens. Those are your nerves that are usually affected. I think those were the only three that I kind of just focused on. Just because those are the only ones that literally you'll see if they're having like increased ICP or anything. All right, next thing, I'm going to go over a stroke. No, the non-modifiable risk factors and modifiable risk factors. I will put them up here in a minute. I am going to delete this page. If I can find my delete button. All right.
Wrong.
So your non-modifiable age, gender, ethnicity, and then your modifiable hypertension. I would focus more on your modifiable always, because we always want to educate them on what they can do to fix their issues. So hypertension, heart disease, diabetes, smoking, obesity, sleep apnea, metabolic syndrome, poor diet, lack of exercise, atrial fibrillation, MI. Your first stroke I'm going to go over is your TIA. Let's see. The only thing I think you need to know about a TIA is that it's a medical emergency. You need to teach people to seek medical attention. Emergency. They're kind of just like warning signs that could lead to a bigger stroke, but it resolves on its own. Just because it resolves completely doesn't mean it's not a medical emergency. That's why we need to tell them it is, because what if it is the one time that it's not going to resolve? Because it can lead to an actual stroke. So they should be coming in. Let's see. Stroke. The next one is your ischemic stroke. So we should all know that this one is usually from blood clots. This results from inadequate blood flow to the brain. You guys should know what these strokes are. I'm just going to go over like the quick important things about them. So there's two different types. I wouldn't know the different types. I don't really think that those knowing the different types are important. There is a thrombotic and then
This
there
how
is an
you-
embolotic stroke. Thrombotic is kind of just like thrombosis. It was like created there. It's kind of like related to your atherosclerotic plaque and the narrowed blood vessels. Your embolotic stroke is an embolus. It's going up to your brain, causing it. Your embolotic stroke can be from AFib. Your thrombic stroke is probably more of like hypertension and bad diet. I think the only thing that's important with this one is TPA. We give TPA. That's the biggest thing. So TPA, you guys know that there is a 3 to 4 hour window. You cannot give it to them if they went to sleep and they woke up with these problems. We don't know what time it happened. We can't give them TPA. It is contraindicated for platelet surgery, your SBP, so blood pressure. That looks weird. I don't know why it says 180. Oh, greater than. It's SBP greater than 185, but I think it's 165. That's a little high. Recent hemorrhage is, I don't focus too much on the blood pressure one. She's never going to be that specific. But recent hemorrhage for sure. Because, you have to differentiate between an ischemic stroke and a hemorrhagic stroke to see if they can give them TPA. And if they're already on blood thinners, they cannot. I think TPA is the biggest point for strokes when you're speaking to the family. I think it's important for you to know, like, if somebody's like, why can't we give them TPA? What's wrong? Usually tell them it's probably because it can increase bleeding. It's not the right kind of stroke. You have to educate them. That's something that's kind of important for ischemic stroke. We'll go over hemorrhagic. You guys done good with this page? I'm gonna delete it. Yeah, cool. Okay, so hemorrhagic is your next one. I don't think she's really big. Like I said, on these, I'll kind of go over more. The next thing I go over is kind of more important about these strokes, but just background information, you should know difference. Hemorrhagic is bleeding in the brain caused by a rupture of a brain vessel. Your most common cause is hypertension. Your hemorrhage commonly occurs during periods of activity. It is most often, there is a sudden onset. So sudden onset with progression over minutes to hours because of the ongoing bleeding. And your signs and symptoms, your neurological deficit, headache, nausea, vomiting, decreased level of consciousness. The only thing I think that's important for this one is knowing it could increase your ICP. Well, it's going to. So put them on seizure precautions. Seizure precautions, and then permissive, just know what permissive hypertension is. We're not going to give them like anything for their hypertension because we want to keep their blood pressure high to help get the brain perfused because it's bleeding out. So whenever it's okay if their blood pressure is high. BP high to get brain perfused. You always want to, and this might be for your proctored, whenever you're trying to differentiate between strokes, you always have to do a CT without contrast first. So CT with no contrast. You have to do that first because you have to rule out a hemorrhage. Once you've ruled out a hemorrhage, you're going to do your CT with contrast, which is just your CT angiography. Because this one will, with the contrast, will show you more of like where the stroke is, where the clot is. But always first thing you're gonna do is get a CT. But first thing, no contrast. And then you have your silent killer, just subarachnoid hemorrhage. Subarachnoid. Silent killer. So they may have warning signs, but probably not. This occurs when there is intracranial bleeding into, and I would probably know, into the cerebrospinal fluid filled space between the axonoid and the pia mater. Your common cause for this one is rupture of a cerebral aneurysm. There's only a couple more things I need to go over for stroke, and then we're going to go over your spinal injuries and we'll be done. All right, you guys done with this page? Cool, I'm deleting it. Clear. Okay, so your next couple of things is knowing the difference between the right-sided brain damage and left-sided. So right-sided brain damage, I think there's a picture in your book. I don't know if it looks like this. I don't know if I got it off of line. I have no idea where I found it, but that one really helps. So your right-sided brain damage, you know, it's going to affect their left side. So they're going to have left side neglect. They're going to be paralyzed on the left side. And the biggest things with this one, so they're going to have regressive and impulsive childlike symptoms. They're going to have a short attention span. And they're going to have impaired judgment, impaired time concepts. That is your right side. Your left side, of course, is going to be right-sided paralyzed. They're going to have depression and anxiety. It's really sad. Depression and anxiety because they are aware that they have these deficits. And they're going to have impaired comprehension. So the left side is more of like language. They're going to have speech aphasia. They're going to have receptive and expressive aphasia. And I think the biggest thing that's super important, difficulty identifying familiar objects. Some considerations for strokes. They're going to be at risk for falls. Always monitor your ABCs. If they have any type of dysphagia, they're going to have risk for aspiration. Always monitor the gag reflex. Monitor speech. And we always want to preserve whatever function they have left. Another important thing, last one, is your carotid endarterectomy. This removes plaque from your carotid. Carotid. That is it for strokes. One last thing to go over.